Hi docs, this is Dr. Yasmin from the Royal Doc Line. I welcome you all to our 5-minute guideline series, where today we are going to discuss the antepartum hemorrhage, which is a green top guideline number 63. The layout of the guideline will be introduction, definitions which are important, prediction and prevention, management, clinical governance, and summary. Regarding the antepartum hemorrhage, this is the bleeding from or into the genital tract occurring from 24 weeks of the pregnancy but before the birth of the baby. Spotting is just the staining. Minor hemorrhage is less than 50 ml and it has settled. Major hemorrhage is 50 to 1000 ml without any signs of clinical shock. Massive hemorrhage is blood loss greater than 1000 ml with and without the signs of clinical shock. Recurrent antepartum hemorrhage is the occurrence of the bleeding which is more than one occasion during the pregnancy. Prediction and prevention of the risk factors. We cannot predict the antepartum hemorrhage, but we can take care of the risk factors to prevent the antepartum hemorrhage. Let's see in abruptio. In abruptio, if there is a one previous history of the abruptio placenta, the chances are 4.4% in this pregnancy. If there are two previous abruptio placenta histories in the same patient, 90 to 25%. Then advanced maternal age, multiparity, low BMI, smoking, artificial reproductive technology, which are the IVF, non-vertex presentation, intrauterine infections, and cocaine and amphetamine has been specifically seen to be associated with abruptio placenta. First trimester bleeding is also associated with increased risk of abruption. Later in the pregnancy, the risk increases from 1 to 1.4%. Factor V leader mutation and heterozygous prothrombin are also associated with abruptio placenta. In factor V leader, please remember it is the heterozygous one. Then unexplained antepartum hemorrhage also puts the patient at the risk of preterm labor, induction of labor at term, stillbirth, smaller babies, and fetal anomalies, and the babies are more likely to be admitted to neonatal intensive care unit and they are at the risk of developing hyperbilirubinemia. So unexplained antepartum hemorrhage, if it happens, it needs a more evaluation and the follow-up afterwards. Here is a placenta previa. This is a table which I have taken from the guideline and you can see there are a lot of the associated risk factors. The cesarean section, it increases the risk of the placenta previa. After one previous cesarean, this is 2.2. After 2, this is 4.1. And after 3, this is 22.4. Previous termination of pregnancy, multiparity, advanced maternal age, multiple pregnancy, previous uterine scars, pre-detach, some mucus, fibroids, and assisted conceptions are also associated with the placenta previa. Investigations. Minor APH. Here you will just do the full blood count, group and save, and coagulation screen is not indicated until unless the platelet count is abnormal. But in major and massive APH, you have to do the coagulation screen, renal function, liver function, Killy-Howard test, ultrasound, and 4 packed RBCs should be available over there. Ultrasound should be done, but the sensitivity in the detection of the abruptio placenta is 24%. But if it is there and it detects that there is an abruption, then the specificity is 96%. CTG is to be done for the fetal assessment. The management, the triaging of the woman is very important. One question is whether to hospitalize or not. It depends upon the amount of the bleeding and the status of the patient. For example, if she just has the spotting and there is no placenta previa, you can discharge her. Bleeding is heavy or continuous, but it is mild now. So you can admit her and observe. If the patient is collapsed, then follow the protocol for the collapsed patient and think about the delivery. Regarding the corticosteroids, as you know, from 24 to 34 plus 6, if there is a mild spotting or the bleeding, but do not wait for the patients who are collapsed. Tocolytics, you can see that there is no place for major antepartum hemorrhage, but the mothers who are hemodynamically unstable or there is an evidence of the fetal compromise, so do not delay the delivery just to give the tocolytics. If the tocolytics is used, avoid nifedipine because of this cardiac side effects. Here is an appendix, how to give the fluid replacement and administration of the blood products. And you have to see if the patient is just up losing 1000 ml with no clinical shock. Just give IV line 1 and commence a crystalloid infusion. But here, if the patient is having massive hemorrhage, then you can see airway, breathing, circulation, oxygen 10 to 15 liters per minute. This is important exam question. And then the cannulas will be 2. tilt the patient towards left, keep the patient warm, and also transfuse the blood as soon as possible, and until the blood is available, infuse up to 3.5 liter of the warmed crystalloid solutions, which is 2 liter, and or colloid 1 to 2 liter as rapidly as required. Here you can see FFP, fresh frozen plasma, usually given 4 units of the FFP for every 6 units of the red blood cell, and our aim is to keep the PT and APTT less than 1.5 times the mean control. Platelet concentrate should be given if the count is less than 50 into 10 raised to power 9. Cryoprecipitate if fibrinogen less than 1 grams per liter. And our aim is to keep the hemoglobin more than 8, platelet count more than 75, prothrombin time less than 1.5 times the mean control, and similar with the APTT time. In the summary, you can see that antepartum hemorrhage complicates 3 to 5% of the pregnancies. Placenta previa and previous number of cesarean sections are important. We cannot predict it. You should always rule out the local causes by doing the speculum, and the patients on the anticoagulant, they should be instructed to stop their medication and use unfractionated heparin in an emergency situation. Clinical governance points are very important, and these are incident reporting, debriefing, skills, and drills. Hope you liked today's presentation. So let's move on to the original guideline, which is antepartum hemorrhage by the RCOG. This is a marked guideline. As you can see, important points are all highlighted. I would appreciate if you subscribe to our channel, like it and share it with your friends. And the link for this guideline is available in our Discord server. Thank you, and I wish you good luck for your exam.